Hello, everyone. Welcome in. We are not going to start officially for another minute or so. I know last week's session had some wonderful music for folks to listen to. We didn't think about that for our session, but we do hope that you feel comfortable uh, joining us today, introducing yourselves in the chat if you feel so moved. Um, get comfortable. We'll get started momentarily. We will put some links in the chat to a slide deck if you'd like to follow along with that today. Again, we'll officially get started in just a moment, but thanks to those who've kicked off introductions in the chat. All right, great. Well, for the sake of time, we will get started, but I know there will be more folks joining us as we go forward. So again, hello, welcome, good morning or good afternoon. Thank you so much for joining us for what is the fourth and final session of this National Learning Series. Today, we're going to be focused on team-based approaches for managing complex health needs. My name is Ariel Mather, and I'm the Senior Program Manager for the National Center for Equitable Care for Elders. I use she, her pronouns, and if you need a visual description, I'm a white woman in my mid-30s and have curly brown hair, light blue sweater. As was already mentioned, we will have links in the chat to a slide deck if you'd like to follow along in that way. Everyone who's registered for this entire series will always get that follow-up email with materials. They're also available on our website, which we will link quite a bit throughout this session. All right, so this is a Zoom webinar. That means all attendees are muted and off camera. Excuse me, we invite you to use the functions at the bottom of the Zoom screen to participate. We ask that you share any questions for our speakers today in the Q&A, and we can keep the chat for introductions and more informal comments and feedback. We'll be sharing any relevant links throughout in the chat and not the Q&A. We encourage the participation of the entire audience through reactions, through emojis, hand raise functions, anything you want to use in Zoom to give us some feedback. That's wonderful. We have enabled live captions for this session. So if you'd like to turn those on, please click live captions in the bottom of your app, select the size, color, placement of those captions. For those who prefer to use keyboard shortcuts on the slide, you can see the available ones for the Zoom functions we'll be using. And if it wasn't already clear, for my own access needs today, I'll be reading from a script. If you have additional access needs or questions, feel free to message us in the chat to hosts and panelists. All right, great. So as you may already know, if you joined us for any previous sessions, this National Learning Series is sponsored by the Health Resources and Services Administration and is a continuation of our previous Special and Vulnerable Populations Diabetes Task Force. This task force, the Population Health Management task Force, is taking a deeper dive into a broader set of issues, HIV, diabetes, and like today, complex needs of those living with multiple chronic conditions that all impact population health management. Again, for more information, our website's a great one-stop shop for information on both our past and present activities, so we encourage you to visit that. A quick snapshot here of all of the national training and technical assistance partners who make up this task force. If you've been to any of our previous sessions this month, you will have met many of these organizations. And you can see again, we're in our last session, so bittersweet, but we've really had a wonderful month learning together with all of you. Again, if you missed any live sessions, the recordings and the slides are available for you, so it would be great for you to tune into those and also to stay in touch with us. We'd love for you to join future activities of our task force, as well as any individual activities of our NTAPs. All right, so here is the wonderful group that will help guide you through the session today. I've introduced myself, but you can see that today's webinar has been developed by teams from 4 different NTAPs. So my own NCECE, we have Migrant Clinicians Network, National Nurse-Led Care Consortium, and the National Network for Oral Health Access. I'll let all my colleagues more officially introduce themselves before their individual presentations, but just want to thank everyone for their efforts and support on this session, as well as Jillian Bird from NNCC and Juliet Provost from NCECE. All right, so if you are not already familiar with our learning objectives today, we do want to start with some foundational discussion on multiple chronic conditions and its impact on the priority patient populations that we serve. And then we'll get to explore several highlights of effective approaches and innovative programs to improve health outcomes and overall care coordination for this population. But first, we'd love to hear from you a little bit more. I love all the introductions in the chat, but we are going to use Mentimeter to dive in a little further with you to learn a little bit more about where you're coming from and get your insights. So if you are used to Mentimeter, you know you can scan this QR code on your phone or go to menti.com and use the code 25770682. If this is giving you any trouble, do not fear. You can put your answers to this in the chat if you'd like, but it is fun to use Mentimeter to see the visual of all the responses. So we encourage you to jump on that if you are able. I see lots of little thumbs up. Thank you. We can go ahead to the first question rather. This one's a real easy one. Show us on this map where you are joining us from today. Nice to see the distribution. Yes, and thank you to those sharing in the chat. Wow, we're spread across. Sometimes we get little pockets of folks. Love to see that. And lots of responses in the chat. Oh, fantastic. Thank you all for sharing. Great. Well, I'm very pleased that there's so many states and regions represented. Thanks for sharing. We can go to the next question. Also a really straightforward one. What's your organization type? This helps, I think, just to visualize who's coming into this type of learning opportunity and what we can learn from each other. We see a lot of health centers, which is obviously our target population, but we welcome those who are in primary care associations, departments of health, community-based organizations. If you selected other, would love to know in the chat the type of organization you're coming from. Home health, I see academic institution. Oh, fantastic. Thanks all. It is so great to get a little visual. All right, let's go on quickly, just for the sake of time. All right, so in a few words, what do you hope to take away from this webinar? Many of you, when you signed up, kind of is the general goal of learning information, sharing it with others, but would love to know, since you chose to come to this final session on team-based care and complex care management, ideas, love it, best practices, absolutely. What else? There's no wrong answers. It's just what you hope to take away. Collaborative techniques. Love that. Sharing with your team, ideas. Excellent. Yeah, learn something new. And it's great to do that in an environment where so many of you have such great experience in this area. You can even offer some insights to your peers, to us, and we can keep that cycle of learning going. We are transitioning to team-based care. Oh, fantastic. That's a perfect opportunity to have this conversation today. Thank you. All right. Okay. Learn more to help my community. I love that. Thanks all. Love these answers. All right. Yeah, let's go to the next item. All right. So when we are thinking about patients living with multiple chronic conditions, what are some common challenges that this population experiences? Could be a lot of different answers here, but I'm curious what comes to mind. It's going to be a word cloud, so if you think about it in a few words, things will start to come together. Things will get bigger, of course, as we get more responses. Medication management, transportation, access to care. Yeah, and thank you so much for all of the chat answers as well. Mental health, lack of disease understanding, quality of life, insurance, health literacy, absolutely. Yeah, well, this is a word cloud where it's interesting to see, but it's also can be overwhelming. These are challenges, common challenges for this population, which is why we are holding this session to talk about some of these innovative approaches, best practices in trying to work as a team to address some of these concerns. So thank you so much for sharing. This is really great. We will include these slides from Mentimeter in the final slide deck. So we hope that that's helpful too for you to take away some insights from your peers. All right, let's go ahead. All right, thank you all for participating. Really appreciate that. Those are the only kind of questions we have for the group, but that doesn't mean we want you to stop sharing. Please do keep comments coming in the chat box. And if you have questions, feel free to put them in the Q&A. So as we all have a good understanding of the basic definition of a chronic disease, the condition that lasts at least 1 year, requires ongoing medical attention or limits activities of daily living, or both. So this is a quick snapshot of some chronic conditions and related concerns. Certainly there could be even more than what is listed on the slide. Let's go to the next. And I do see someone's hand raised. I would love it if you could put a question in the Q&A or send a message to hosts and panelists. We'd love to be able to connect with you. Great. So most of us are already familiar with the many complexities of living with and caring for a chronic condition. There's no one single cause, nor a one-size-fits-all approach to its treatment. So this mismatch between care delivery that is heavily disease-specific and the unique needs of patients can result in lower quality care and an increased fragmentation. Poor outcomes can include avoidable hospitalizations, increased healthcare costs, and other adverse events. So 1 in 3 American adults, 4 in 5 Medicare beneficiaries, and a growing number of children have more than two or more chronic conditions. The impact of multiple chronic conditions, or MCC, will vary depending on a few different factors. So severity of illness, your functional ability, societal drivers of health, experienced by an individual patient. So improving care for individuals living with MCC requires us to understand the context of their lives and then take care of them accordingly. To visualize this a little further, you can see the disproportionate healthcare use and spending for individuals with MCC. The reality of the situation is that these are individuals with complex medical, social, psychological needs who then need to interact and navigate with a health system that can also be extremely complex. The members of this task force, and especially of our subgroup today, are all focused on a special patient population, a priority patient population or topic in the training and technical assistance we do for those individuals who are at particular risk for MCC that also have limited resources to support their navigation of this complex health system. Because my NTAP does focus on the health of older adults, I did want to just make a note that the number of adults over the age of 65 is rapidly growing. By 2030, 1 in every 5 Americans will be an older adult. And by 2060, that will increase to 1 in 4. Sorry, I'm just looking at hand raises. This population is more likely already to be living with multiple chronic conditions, and as patients develop more conditions with age, providers need to be aware of special risks that face this group, including for their mental health. While a multimorbidity weighted index scoring approach has been mostly useful in research thus far, there's a growing interest in providers using this tool to better understand the care needs of patients living with MCC. While not intended to be a complete indicator of a patient's prognosis, it can help guide conversations about an eventual decline in physical functioning and related decisions. So it could be preventive care, surgery, living arrangements, end of life preferences. It's important to note that higher multimorbidity scores impact a person's functional age. So an adult younger than 65 could be impacted to the extent that their health is similar to someone who is much older. Those with higher scores have also been shown to have a much faster decline in their cognitive abilities than those with lower scores, even if their conditions have no direct impact on the health of their brain. But we do understand that the risk of cognitive decline and poor mental health is in the larger context of a patient's unique set of conditions and the impact on the quality of life. All right, so just a quick note, this is something that we all are very aware of. For many, COVID-19 compounded existing factors related to MCC, food insecurity, social isolation, substance misuse, other lifestyle behaviors like healthy eating, physical activity. This population was particularly vulnerable to health complications from this virus and may have had or currently have additional challenges presented by long COVID. So this will continue to be a significant concern in the care of this population going forward. All right, so we had some great responses as far as challenges that could be experienced by patients with living with multiple chronic conditions. Just want to quickly note some general buckets of barriers related to effective care for these patients. So delivery system issues. I mean, again, with such complex needs, diversity of needs, this is really going to depend on the knowledge and experience of an interprofessional care team that can tailor their approaches to those unique needs. In the absence of that, if the health system serving them doesn't operate in that way, they're less likely to receive and benefit from truly effective care. Certainly, multiple chronic conditions means there are multiple sets of condition-specific guidelines, the interaction of which may put the patient at risk for harm, especially long-term, that's less studied. Certainly, we talk quite a bit, I think, in our learning activities around the relationship between a patient and clinician or other staff member. Um, in this relationship, is there good communication? Is there established trust? Do we have adequate connections to related community services? Limitations of time and other resources really can significantly impact the rapport we have with a patient and the likelihood that they can comfortably adhere to a care plan. And then finally, in thinking about what matters to the patient, are their unique needs and preferences incorporated into their care management? What personal or environmental factors may impact their ability to successfully self manage their chronic conditions? If we aren't able to explore this and acknowledge it, there's going to continue to be barriers to receiving optimal care. We are really excited to hear from our other panelists today about some approaches to address these barriers. But before we jump into that, I have one final note as I love to talk about health communication. The guide linked in this slide offers some really valuable information on the language we use and the messages we send when discussing complex care. When it comes to engaging the patients themselves, we want to reflect on our own understanding and perhaps some assumptions of the individual's role in managing their health and improving their own well-being. So these are kind of reflective questions for us to ponder on. So how do we view the patient's responsibility in all of this? We want to be sure that we understand that patients are often not the source or unaware of the source of the problem and are not solely responsible for the solution. This is a collaborative effort. How do we actively involve them in goal setting, management plans? This is going to be crucial to setting achievable goals and staying consistent in care plans. Related to achievable is self-efficacy, is that self-confidence of a patient to manage their own health, to navigate that complicated system. The belief that someone can do or accomplish something, even if they haven't done it before, is really important to prioritize. So we're going to be able to equip those patients to better understand the steps that come next in their care. And then are we allowing the patient to define what success looks like? So you want to think about goals and the concept of success beyond just a clinical outcome. Certainly, if someone would benefit from a lower body weight, that's great. But maybe the goal for the patient is they want to be able to walk with their grandkids more outside. Maybe there's a clinical goal of controlled blood pressure, but the goal of the patient is they want to be able to resume a hobby that they once loved. There's a lot of different ways to frame these goals that focus on a patient's priorities, their preferences, and hopefully will really be able to motivate them to make appropriate changes or to adhere to the agreed upon care plan. So I wasn't able to follow all of the chat, but I do love, thank you for the comments of it's super important to involve the patient in their own care. Absolutely. So with that, I'm going to turn it over to my colleague, Matt. I'll say that we'll have 3 brief presentations here. We'll try to pause momentarily after each if there are specific questions, but please do keep your comments and feedback coming in the chat, as well as putting any questions in the Q&A. So with that, I'll turn it over to Matt.
Thanks, Ariel. Can everybody hear me okay? Yeah, okay. Hi, guys. My name is Matt Beierschmidt. I am the Senior Program Manager for NTAP at the National Nurse-Led Care Consortium. And I'm going to speak on importance of team-based care. Next slide. So health centers are vital in promoting health equity by ensuring access to high-quality care for vulnerable populations, including those with complex chronic needs. By optimizing team-based care models, health centers can effectively address disparities in healthcare access and outcomes, ultimately improving population health and reducing healthcare costs associated with preventable hospitalizations and emergency department visits. Next slide. The National Academies of Medicine defines team-based care as team-based healthcare, which is the provision of health services to individuals, families, and/or their communities by at least 2 health providers who work collaboratively with patients and their caregivers to the extent preferred by each patient to accomplish shared goals within and across settings to achieve coordinated, high-quality care. In team-based models, healthcare professionals from various disciplines, including physicians, nurses, social workers, pharmacists, behavioral health specialists, and community health workers, work together to develop personalized care plans tailored to each patient's specific needs. This collaborative approach enables comprehensive assessment, holistic management, and continuous monitoring of complex chronic conditions, improving health outcomes and patient satisfaction. Next slide. On this slide, you can see the traditional patient relationship model and the team-based care, patient-centric care model. Key components of team-based care within FQHCs include care coordination, patient education, self-management support, medication management, and proactive follow-up. When optimization care for patients with complex chronic conditions, healthcare providers emphasize several key components. One is interdisciplinary care teams collaborate closely to deliver comprehensive, holistic care tailored to each patient's need. 2, care coordination is another essential aspect, ensuring seamless delivery of services across different providers and settings. Number 3, a patient-centered approach prioritizes the preferences and goals of the individuals, fostering trust, engagement in decision-making. And 4, integrating primary and behavioral healthcare services within the same setting or through partnerships enhances early identification and treatment of mental health concerns while addressing physical health needs. Next slide. This is a kind of, this slide kind of gives the overview of the approaches for managing complex health needs. And through these components, healthcare organizations aim to improve patient outcomes, satisfaction, overall well-being, and managing complex chronic conditions. Here are some examples of the members of the care team that make up interdisciplinary teams. Providers are primary care providers are responsible for overall patient care, diagnosis, treatment, management of chronic conditions. Under providers, you have specialists. They provide expertise in medical areas relevant to the patient condition, such as cardiology, endocrinology, neurology. And we also have care coordinators under providers. They facilitate communication between different healthcare providers, coordinate referrals to specialists, and ensure continuity of care. Another component is nurses. That includes registered nurses who assist in patient assessment, monitoring, and education, administer medications, and coordinate care plans. And also includes nurse care managers who coordinate care plans, monitor patient progress, provide patient education, and support self-management strategies. We also have social workers in here, and that includes medical social workers who assess psychosocial needs, providing counseling and support services, connect patients with community resources, and address social determinants of health. And under that, under social workers, we also have care coordinators who assist patients with navigating the healthcare system, coordinating services, and advocate for patient needs. We also have pharmacists as one of the components, and that includes clinical pharmacists who collaborate with healthcare teams to optimize medication therapy, conduct medication reviews, educate patients on medication use and adherence, and manage medication-related issues. And then we also have medication reconciliation specialists, and they ensure accurate, up-to-date medication lists, reconcile discrepancies, and identify potential medication-related problems. Then we also have another component is behavioral health specialists, which is psychologists, psychiatrists, which provide assessment, diagnosis, and treatment for mental health conditions such as depression, anxiety, or substance abuse. And we also have licensed clinical social workers under behavioral health specialists, and they offer counseling, psychotherapy, and support services to address behavioral health concerns and promote coping strategies. And then finally, we have under community health workers, we have health educators, provide health education, information on chronic disease management, preventive care, and healthy lifestyle behaviors. We also have patient navigators who assist patients in accessing healthcare services, scheduling appointments, arranging transportation, and overcoming barriers to care. And last but not least, we have outreach workers who engage in underserved communities, conduct healthcare screenings, and connect individuals with healthcare resources and social support services. By integrating the expertise and contributions of these diverse professions, interdisciplinary care teams can provide comprehensive patient-centered care that addresses the complex needs of patients with chronic conditions, leading to improved health outcomes and enhanced quality of life. Next slide. In considering and refining the principles of team-based care, we know that while teams are groups, they're also made of individuals. Each healthcare team is unique. It has its purpose, its size, its setting, its core members, and communication methods. Despite these differences, we sought to identify core principles and embody everyone's teamness. So some principled team-based healthcare principles are shared goals. The team, including the patient and where appropriate, family members and support persons work to establish shared goals that reflect patient and family priorities and can be clearly articulated, understood, and supported by all team members. Clear roles. There are clear expectations for each team member's focus, responsibilities, and accountabilities, which optimize the team's efficiency and often make possible for a team to take advantage of the division of labor, thereby accomplishing more than the sum of its parts. Mutual trust. Team members earn each other's trust, creating strong norms of reciprocity and greater opportunities for shared achievement. Effective communication is an important principle. The team prioritizes and continuously refines communication skills. It has consistent channels for candid and complete communication, which are accessed and used by all team members across all settings. And then also measurable processes and outcomes. The team agrees on and implements reliable and timely feedback on successes and failures in both the functioning of the team and the achievement of the team's goals. These are used to track and improve quality of performance immediately and also over time. Next slide. There are several successful team-based care models. We have demonstrated effectiveness in managing complex chronic needs. Here's a few examples. We have the patient-centered medical home, the PCMH model, is a primary care delivery model emphasizing team-based care, care coordination, patient-centeredness, and PCMH models. Interdisciplinary teams, including physicians, nurses, pharmacists, social workers, and other healthcare professionals, collaborate to provide comprehensive, coordinated patient care. MH's focus on the proactive management of chronic conditions through preventative care, care coordination, and patient education, leading to improved patient outcomes and satisfaction. And then I'm not, for the sake of time, you can see the other, we also have the chronic care model, the CCM. We have the collaborative care model, the COCM, and the team-based care and accountable care organizations. These are the four models, the four bullet points, kind of breaking down for you. So feel free to review those. But I'm just going to basically read off the slides. So I'll let you read off the slides at your own pace. And next slide. So we have health centers can utilize existing workforce of health professionals, including providers, nurses, social workers, pharmacists, and behavioral health specialists to form interdisciplinary care teams. By effectively coordinating, integrating the skills, expertise of team members, health centers can provide comprehensive, holistic care to patients with complex needs. Health centers can invest in health information technology systems, such as electronic health records, and telehealth platforms to support team-based care. These technologies facilitate communication and sharing information among team members, streamline care coordination processes, and enable remote consultation and follow-up care. And we also have health centers can redesign their physical space to support team-based care delivery. This may involve creating shared workspaces for interdisciplinary teams, co-locating primary care and behavioral health services, implementing collaborative care models such as co-located or hub and spoke models. Health centers can also invest in workforce training and professional development opportunities to enhance their knowledge and skills in team-based care. This may include continued education on collaborative practice models, interprofessional communication, and cultural competency training. And then finally, health centers can establish partnerships with healthcare providers, community-based organizations, and social service agencies to expand their capacity to deliver team-based care. These partnerships may involve sharing resources, coordinating services, and/or collaborating on initiatives to address the social determinants of health. So that's all from me now. I believe I'm passing it now on to Teresa from the Migrant Clinician Network, and or Ariel. Go ahead.
Yeah, we're going to have Theresa go very soon. I do want to, Juliet, if you could go back to the one of the graphics that was the circle with the team. We had some really great discussion in the chat that I do want to acknowledge, especially for folks listening to the recording. What's clear is that really we could make this a much, I mean, and this wasn't a graphic that we specifically made. I'm not sure, Matt, as far as NNCC goes, but there was some questions around where does certain role fit in, and kind of the need for being even more explicit about some of the roles. So we had questions around oral health, which is fantastic. We're going to have a focus on that later today. To really have a pharmacist and pharmacy care team kind of separate, so folks understand their specific role. Obviously, there's some complementary efforts implied, I think, in this graphic. Wellness coaches, CHWs, let's see, interpreters. Want to mention nutrition. So again, I think there's some of this where there's some of it that's implied, but I love the emphasis on being as clear as we can of acknowledging truly just how many folks it takes, knowledge and expertise wise, on a team to make sure that that patient and their family, their informal caregivers, get the quality care that they need. So just want to note that. I wasn't sure if anyone else had additions. It really, would be a fun project, I think, for us to, and we don't have time for it today, but if we were to take the graphic and in a Mentimeter style, everyone starts adding some sticky notes to it, because I really appreciate everyone's insights. And I think it would be great to, again, have a very large graphic that's inclusive of truly all of the roles that make this work. So that's all I'll say for that. But Tharisha, we'll pass it over to you to talk about a program highlight. Oh, you're still muted.
Now you can hear me. I'm Tharisha Lyons-Clampett, Senior Program Manager for the Migrant Clinicians Network, and I'm going to talk to you today about a program called Health Network. Next slide. First of all, just a little bit about MCN. Our mission is to create practical solutions at the intersection of vulnerability, migration, and health. And that is because we envision a world based on health justice and equity where migration is never an impediment to well-being. Next slide. This is just a slide that shows you our locations across the United States and in San Juan, Puerto Rico. Next slide. All right, so we're going to talk about Health Network, which is a care coordination program for patients who move during treatment. Next slide. And the purpose of Health Network, again, is to eliminate the health disparity due to patients' mobility. Next slide. It's important for you and for patients who you might refer to this program to know that MCN Health Network does not discriminate on the basis of immigration status, and we will not share personal patient information without patient permission. Next slide. And of course, everything is confidential. Confidentiality is critical to MCN staff, and all Health Network procedures conform to HIPAA standards. In fact, all staff that work for MCN takes HIPAA training and is required to have a certificate. And then all patients are asked to sign or have a witness sign a consent form before enrolling them in Health Network. Next slide. These are the forms that we ask for that are required to enroll a patient in Health Network. And I'll share, I think at the end, there are some links where you can actually look at these slides, these forms and download them for use. Next slide. Important to know on these slides is that this gives MCN legal permission to transfer participants' medical records and contact them to help them find healthcare wherever they are moving to at each time that they move. And it's valid if sent within 5 business days. We actually can receive them later than 5 business days, but we have found that it's really important for us to make contact with your patient within 5 business days for it to be a really successful collaboration. And patients need to be enrolled in the beginning from a healthcare facility, because the work that we do is to help them find a care at their next location and to make sure that their medical records go along with them, so there's no delay in care of what they need. And then finally, the consent form is valid for 24 months. After 24 months, if the patient still requires our help as they move about the country, the patient can renew the second time. Next slide. On our website here at this location on the slide, we have some informational videos about Health Network and those links where you can download the enrollment packets, which we have in English, Haitian Creole, Portuguese, and Spanish. Next slide. Just a recap of Health Network enrollment criteria. The patient, first of all, the patient is mobile or migrant and thinking of leaving the area of care. And the reason we put thinking of leaving the area of care in there is because oftentimes a physician may see a patient and do a test, and they are needing to wait for the test results to come back. And they may know that the patient is mobile and only going to be in the area for 3 to 6 months, and they think, I'm going to see them next time, I'll enroll them next time. And then something happens in their life where they leave and the test result comes back needing follow-up. So we always ask folks that if they know they have someone who's highly mobile, who potentially may have a chronic illness that needs to be followed up on, that they go ahead and enroll them. Even if they're not leaving yet, we can always hold that enrollment until they leave. But that way we have been able to meet the patient, describe our services to them, and then if something happens in their life where they leave before they get to see you again, we can pick it up from there and make sure that they get the follow-up that they need. And second, then the patient needs to have a clinical follow-up, like we've been talking about. They have a working phone number or a family member with a phone number that we can reach out to let them know we're trying to reach them. They will sign the consent form and just some clinical base or enroll in clinic, as I discussed earlier. Next slide. Some steps to maintaining patients in care. Next slide. Again, I'll mention the contact that we contact patients on a scheduled basis, and that's why we need phone numbers to be able to reach them. It provides an enrolling clinic with we provide an enrolling clinic with monthly updates, and provide receiving healthcare clinics with updates as requested. And again, we assist patients in locating clinics for services and resources where they're going to be going. And we report back again to the enrolling clinic to notify them of final outcomes. Next slide. The patient also has a role in staying current with us. And so next slide. Providing us with as many phone numbers as possible. Sometimes we'll have 3 or 4 phone numbers for a patient because they're not sure that their cell phone is going to work in one or more of the places that they travel to for work. And in that case, we can reach out to their alternatives. And in the enrollment form and the consent form, there's a place for the patient to say whether or not we can leave PHI with anyone that they're listing on as a contact for them. If they don't want us to do that, then what we do is just to let them know that we're trying to reach them and ask them to give us a call. Next slide. Informing Health Network associates of any phone changes or address changes, plans to leave the area, and dates of that is very helpful for us so that we can help to plan in advance where they're going to need to have their next healthcare appointment. Next slide. Continued treatment as long as indicated by their physician. We are not physicians. We are patient navigators and bridge case managers. And so following the instructions that the doctor has given them is very, very important, and we back that up. Next slide. To date, we have provided services to over 15,000 mobile, mostly agricultural workers across the US and into other countries. Next slide. And you'll see here that we have worked with over 3,000 total clinics in the US and into 114 countries that we're engaged with to eliminate mobility as an obstacle to continuity of care. Next slide. And you wonder, how can MCN have such a high completion rate? Because we do. We have a pretty high completion rate in working with these 114 countries. Our case managers are multilingual, multicultural case managers who use multiple communication techniques, and they speak multiple of languages: English, Spanish, Haitian, Creole, French, Portuguese, and some others I don't have listed here. And if there is a language that we don't speak, we use language lines. Next slide. This is just a shot of the general type of patients that get enrolled in the breakdown. And I'm going to go ahead and skip to the next slide. And then we also have a portal that we put together for health centers that enroll often with us to make it easier for you to get your paperwork in for enrolling a patient and the medical records. Next slide. And here's a slide to let you know that if you're already enrolling patients with Health Network and you have a question about your patient, you can reach out to Alma Calmanero, and her email address is here and her phone number. Or if you'd like to schedule a training more in depth on this topic and this service to you that's free, you can reach out to me and I'll set that up for you. And now I just pause for a couple of questions.
We don't have any questions at the moment, but encouraging folks to put things in. I do want to go ahead with Irene's presentation just for the sake of time. I do see a question in the Q&A, Theresa, around where to find health education resources in Haitian Creole. Maybe it's something where you could start to type an answer and we can circle back to that.
Absolutely.
Wonderful. Thank you.
All right. Thank you.
Great. Hi, I'm Irene Hilton. I'm the dental consultant for the National Network for Oral Health Access, and we're the oral health NTAP for all things teeth, gums, and mouth. And I'm going to talk today for a couple of minutes about a project that we've been doing for 4 years, which is kind of like a rubber meeting the road example of what it takes to actually create whole person care and team-based care in the health center setting, leveraging the potential for co-location and integrated health records, and again, physical proximity and sharing of patients within community. Next slide. So the project that we've been working on for the last 4 years involves co-managing 2 chronic conditions. One of them is diabetes, and the other one is periodontitis, which is a form of chronic gum disease. And as you can see from this slide here, we've got the data on the left is from the UDS, and the data on the right is from NHANES, so it's health center populations and the nation as a whole. But you can see that individuals that are disproportionately affected by these 2 conditions kind of align in terms of race, ethnicity, and income level. Next slide. And clinically, biologically, there's this relationship between these 2 chronic conditions, between diabetes and gum disease. So if you have diabetes, you're much more likely to have gum disease and different oral health issues. And if you have chronic periodontitis, chronic gum disease, that can impact your glycemic control. Next slide. So given that, the aim or goal would be to try to get patients that we see in health centers with diabetes into dental care. But as most of you probably know, even within our own health center system, there's an inequity in terms of being able to access the capacity of health center dental clinics is about a quarter of what the medical primary care capacity is. So even within health centers, decisions thoughtful decisions have to be made, and systems created to get specific populations into dental care, because it's really not available to everybody. Comprehensive care. Next slide. So again, over the last 4 years, we have been running year-long quality improvement collaboratives with between 10 and 12 health centers a year from across the country. And so these are some of the things that we have learned, again, about actually developing systems to actualize and make the concept of whole person care and team-based care that you saw earlier with the patient in the middle and all the other people, that doesn't just happen. Again, systems have to be created and challenges addressed. So again, the goals of this collaborative is that we have clinical bi-directional best practices for both the primary care side and the dental or oral health side of health center programs to help in the management of patients with diabetes. Again, we're trying to increase access for health center patients with diabetes and improve general health. Next slide. So here you can see, and of course, we don't expect you to like memorize this, but basically on the left hand is the workflows and the activities that are on the primary care side, and on the right hand side are the workflows and activities that belong to the dental side. And we, again, the work that gets done during the year is development of, and there's training components involved, and again, developing referral systems and working with the health record systems to be able to create, again, this busy, but basically what it comes down to is primary care providers looking at their patients with diabetes, especially the ones that have A1Cs over 9, doing visual assessments, and again, creating a referral system to get them over to dental. On the dental side, dental being trained to look up the A1Cs of the patients, again, in the population of focus, A1Cs over 9, making sure their A1Cs are current. And if they're not current, to either make a referral, a warm handoff, or in some cases, in some health centers, even doing the A1C point of care testing themselves in dental. So again, every health center that's been involved in the collaboratives has developed different strategies to work on both sides of this. And again, it's a long process because again, this infrastructure isn't there of training and knowledge for the separate, the disciplines, the creation again of infrastructure in the EHRs for documenting data and referral process. And again, just working out the workflows for all of these things. And that's what we're doing using quality improvement structure. Next slide. So here what you can see is, and this is from the first 2 years, and this is an aggregate, right, of the data that was turned in by the first 2 years of health centers that participated. And we use a marker of the dual user rate, which was the percentage of patients in the individual health center population of focus, people that individuals with A1Cs over 9 that actually had a dental appointment, within the year. And it's interesting because everybody seemed to think that, all the patients with diabetes, and especially ones that, A1Cs over 9 were getting into dental care, but the average baseline was like 11%. So actually patients were not getting into dental, the ones that really need to go, like I said, to help with their, like I said, manage their glycemic control. So again, you can see that over time with the systems, it did increase. Next slide. So just some of the strategies that we developed was, again, being able to, in the medical side, insert some oral health assessments into the EHR that prompted, MEAs doing the oral health assessments, creating electronic referral to dental in the system, and again, using either diabetes or medical side care coordinators to make the dental appointments. On the dental side, it'd be training so the staff could learn where to look up at A1C in the record, understand what A1C, what levels of both A1C and daily glucose impact on dental treatment. And again, even some people are actually doing their own A1C testing in dental. Next slide. We've had to create a lot of resources. Now, unfortunately, these are not available yet because we're still testing them and refining them with each successive yearly cohort of health centers. But we had to develop a resource to assist dental side in understanding the clinical implications of diabetes and A1C and blood glucose on dental treatment, on daily dental treatment. And then here's an example of a risk assessment, these questions again that are being asked on the medical side of patients with diabetes, usually by support staff to aid in the making a referral. Next slide. So in conclusion, that was just an example again of how to actually, again, actualize and develop the whole person, the whole person care, the team-based care, some of the things that have gone into, at least in this project, in terms of, again, trying to address these two chronic conditions of diabetes and periodontal disease. So
Fantastic. Yeah, thank you so much, Irene. We have a few minutes for questions. Do want to note that there are some additional resources that you'll have available in the slide deck if you want to do some more general reading around best practices, understanding populations with multiple chronic conditions. I know we had some good discussion questions-wise. In the chat around material translation. I put a link to the clearinghouse in the chat that I hope you'll find useful to search by. If you have other questions, please do put them in the Q&A or the chat now. Irene, oh, I see you're typing an answer, but do you wanna verbalize your answer around how we kind of understand if the medical side, the dental side are working together, if they're working together effectively?
Well, so 80% of health centers are either contracting with an outside provider for dental services, or they have at least one site with a dental clinic. So again, there's the challenge is you may have 10 medical clinics and one dental clinic. So that's what I mean about, but at least, there's a potential to, again, use the fact that somebody is co-located, or you can use the electronic records, so there's a potential for greater ease of creating team-based care with the dental department than, let's say, there would be if you were trying to go to an outside provider, because they're not going to even have the potential for electronic record viewing. So now the level of integration and cooperation at each health center is going to vary greatly.
Absolutely. Someone in the chat, let's see, please point me to a great resource for correlating A1C value with the degree of severity of periodontal disease. Do you have any particular NOAA resources, Irene, that would help to make the case there?
Okay, sorry, can you read? Oh, here, please point me to great. Usually, yeah. Most of the time, the higher it is, the more the longer you've had an A1C over 9, the more likely you are. Again, if you've had chronic out of control diabetes for a long time, you're more likely to have chronic, worser case of gum disease. I can't really say there's Actually, there are some studies that show that, again, A1Cs over 9, individuals that have higher A1Cs have more severe, if you're grading periodontal disease, it's more severe. That's actually in the NHANES, another part of that NHANES data. So that actually, if you Google NHANES and then diabetes and periodontitis, hopefully it'll pop up those studies. So I do know, Debbie, I guess if you could put your email in the chat, I can send you some stuff. Or actually, why don't you email me, sorry, at irene@noaa.org, and I can send you some references.
Great. And yes, in one of our final slides, we do have email addresses linked for staff from each of our organizations. We'd love for you to be in touch. We do have Matt's colleague Jillian linked here, but we can have Matt put his email in the chat as well. We're almost at time, so I do want to make sure everyone has a moment to fill out our quick survey. We offer this at the end of every session to create better training and technical assistance activities going forward, to get insights on what were the most helpful parts. So if you could take just a moment to fill that out, that would be so appreciated. Again, this is our final session for this series, but we do hope that you'll stay tuned for future activities. We'd love to stay in touch. Yeah, Irene, closing
I just want
thoughts.
to acknowledge my colleague, Yash from Texas Health Center, who actually put a link in the chat to an article on the relationship between diabetes and periodontal disease that you can link to, that the person that chatted in can link to that explains it all.
Wonderful. Thank you. Yes, and for those worried about not being able to click on links now, you will get a PDF of the slide deck. That includes the Mentimeter responses too, within the next week, and you should be able to interact with all of those links at that point. So we are just about at time. We appreciate everyone's participation. Thank you for sharing your own insights. We loved learning with you. We hope we'll see you again soon. Thanks so much. Have a wonderful rest of your day. Take good care.